Now for cholecystitis. This is inflammation of the gallbladder, typically caused by gallstones, also called cholelithiasis. Now these little stones block the ducts that lead out of the gallbladder, resulting in a backup of bile, which causes inflammation. Now the main risk factors include a high-fat diet, obesity, as well as age over 40. And for some reason, females are more susceptible than males. Now the signs and symptoms are key, so write this down. Number 1 is right upper quadrant pain that radiates to the right shoulder, since this is where the gallbladder is located, right here near the liver. And we also see fevers with chills, as well as tachycardia, since the inflammation can lead to infection. Now again, write these 3 down and know the location here. Always highly tested on Select All That Apply questions. Now, don't let the NCLEX trick you here. Not left upper quadrant pain that radiates to the back. That's typical of pancreatitis on the other side of the abdomen. So Kaplan mentions, priority findings for acute cholecystitis include tachycardia. Now, other signs include vomiting this greenish yellow bile, and pain will get worse from eating high greasy or high fatty foods. Now, if we have a blockage in the bile duct due to a stone, the patient may show signs of high bilirubin, like jaundice, dark urine, yellow of the eyes, and even clay-colored stools from that elevated bilirubin. And also the lack of enzymes from the pancreas can lead to statorrhea, that fatty stool, from excessive fat inside the stool, from the lack of lipase. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for hepatitis. This condition refers to inflammation of the liver, commonly caused by a viral infection. And non-viral causes are typically caused by alcohol and even autoimmune diseases, where the body attacks itself. Now there's 5 different types of hepatitis: A, B, C, D, and E. But really the most tested here are B and C, so I bolded them here. So starting at the top, type A is transmitted by fecal-oral route, typically through contaminated food. And B and C are typically transmitted from blood and body fluids. Now, D is a co-infection with type B, and E is the fecal-oral route, typically contracted from contaminated drinking water. So the memory tricks to know for exams is A, think anus to mouth. For hepatitis B and C, just think blood cultures as well as sex. And E, just think E. coli is in the water from drinking contaminated water. Now, in terms of causes and risk factors, for B, C, and D, we have blood and body fluids. So IV drug use, as well as tattoos or even body piercings, and even sharing razors or unprotected sex. So a common NCLEX question talks about modes of transmission for hepatitis C. Select all that apply. So just think hepatitis B and C is from blood cultures, B and C, as well as body fluids. So option number 1, blood, is correct. Option 2 and 3 are incorrect here. Remember, we're looking for blood and body fluids. And option 4 and 5, semen and vaginal secretions, yes, that is correct for hepatitis C. Now, in terms of signs and symptoms, when caused by a virus, which is the most common, we see flu-like symptoms. So we see a headache, fever, fatigue, also called malaise, as well as nausea and vomiting. And a key term here is elevated liver enzymes, because in hepatitis, we just have inflammation of the liver. So naturally, you will see an elevation in liver enzymes with elevated ALT and AST and elevated bilirubin. Now, normal for any liver disease, we see common signs like itchy, also called pruritus, from bile salts that build up under the skin. We get that elevated bilirubin, as mentioned before, so we'll see jaundice, basically that yellowing of the skin and the eyes. We'll also have colored urine, as well as clay-colored stools, typically described as pale stools, from all that bilirubin spilling over into the bowels. We'll also see elevated PT and APTT. That leads to bruising from the lack of coagulation factors, as well as low albumin. So we see edema since albumin is not there to attract the water back into the blood vessels. Now, a little side note for pathophysiology. The 3 stages of hepatitis with correlating signs and symptoms. So number 1 is the prodromal or preicteric stage. This is defined as general non-specific manifestations like malaise, fatigue, muscle aches, nausea and vomiting, and even anorexia. Moving on to the second icteric stage. These manifestations are a little bit more serious. So we see jaundice, light clay-colored stools, and even darker urine. And lastly, number 3 is the post-icteric stage. This is known as the recovery stage. So Sonder mentions, the nurse is teaching the client with viral hepatitis. This disease is characterized by which specific assessment finding. Select all that apply. So jaundice, clayed color stools, elevated bilirubin levels, as well as dark or tea-colored urine. Now, all these signs are from that elevated bilirubin that spills over into the bloodstream, making the entire body yellow. So this is typical for any client with liver disease, specifically with cirrhosis as well. And we go into way more detail in that video. Now, for a top missed NCLEX question about hepatitis. A client is admitted with hepatitis and complains of constant itching. Which intervention would the nurse recommend? So, option 1, applying a moisturizer. Option 2, avoiding the sun. Yes. And option 3, applying a cold press. Yes. And option 4, applying a hot pad. No, we want to avoid the hot pads and choose the cold. So, option 1, 2, and 3 are the correct ones here. So, itching is a very common complaint after hepatitis, so it's best treated with a cold press, moisturizers, as well as staying out of the heat. Now, in terms of diagnostics, the antigens are not highly tested, so I recommend not focusing on that too much. But a liver biopsy is tested, specifically after the procedure. We teach clients to lay on the right side, basically to lay on the liver, to prevent bleeding. So we always put pressure on anything that is bleeding. In that same way, we're putting pressure on the liver to prevent that bleeding. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Oh, who lives in the abdomen next to the spleen? The pancreas secretes insulin and digestive enzymes. The pancreas, islets of Langerhans beta cells to secrete insulin to open the cells and let sugar inside for energy. Ready? The pancreas secretes enzymes and insulin. The pancreas. Join simplenursing.com. Okay, hopefully you guys liked our pancreas song. You can get it for $1 on iTunes and even Google Play if you have an Android. And we also have 8 more songs in our full album. Simply search Simple Nursing on your music store. Now for pancreatitis. The pathophysiology is very simple. In pancreatitis, we have inflammation of the pancreas. So anytime you see the word itis, just think inflammation. So in pancreatitis, this inflammation comes from autodigestion of the pancreas. Basically, the pancreas's own digestive enzymes have accidentally activated early. Now, as you know, the main functions of the pancreas is exocrine and endocrine. The exocrine part is to produce digestive enzymes, which helps break down food and is a critical part of digestion. And the endocrine is for secretion of insulin and glucagon. to stabilize glucose balance, which we cover in the diabetes lectures. Now, the enzymes are the key here. They are like ticking time bombs to break down and digest food. But when they're activated early inside the pancreas, they actually digest the pancreas. So the three key enzymes to know is protease, which breaks down protein. Lipase, one of the biggest affected by pancreatitis, breaks down fats. So just think lipids and lipase, lipid for fat. And lastly, amylase breaks down carbs or carbohydrates. Now, if the pancreatic duct is blocked for any reason, say from inflammation in liver cirrhosis, or hepatitis, or let's just say a gallstone has floated down and got stuck, well, this means that the enzymes can't get out of the pancreas and into the intestine, and accidentally prematurely activate within the pancreas. It's kind of like having a pirate ship, and you know how they shoot out cannonballs. But what if those cannonballs explode within the pirate ship and sink your ship? Well, in the same way, it's kind of like having these enzyme bombs exploding inside the little pancreas here, causing supersized inflammation as the pancreas digests itself. This is what is meant by autodigestion. The causes are very simple. Again, think anything that can block this little tiny pancreatic duct. As you can see, we have a lot of organs closely fitted together here, kind of like an apartment complex. They all share this common bile duct, which branches off into the pancreatic duct here. So, common causes is alcohol abuse from years and years of inflammation, which ends up inflaming the little duct and occluding it, or basically blocking it. Now, gallbladder disease as well, we talked about a gallstone or even inflammation that now blocks this duct. And even cystic fibrosis, where we have serious mucus with cystic fibrosis. This mucus can block the pancreatic duct. Now, a really odd one here is surgeries, or a diagnostic procedure that can accidentally cause trauma and inflammation in this area. Now, this is very common with an ERCP procedure, an endoscopic retrograde cholangiopancreatography. Big long word. So please write that down. ERCP. This one is highly tested. Typically used to clear gallstones or diagnose problems in the bile duct, a scope is passed through the mouth, down through the small intestine, and through the bile and pancreatic duct too. Now, if this scope accidentally scratches the duct here, it can cause major inflammation, which blocks the pancreatic enzymes from getting out, leading to pancreatitis. Now, in terms of the signs and symptoms, pain is a huge NCLEX tip, so write this down. Epigastric pain, like heartburn, in the left upper quadrant. So, left upper quadrant pain that radiates to the back. Huge key terms right there. Write those down. The majority of the pancreas is in the upper left quadrant here. So, don't let the NCLEX trick you. It's not the right upper quadrant pain that radiates to the shoulder. This is typical of gallbladder inflammation on the other side, called cholecystitis. And it's not right lower quadrant pain with rebound tenderness. That's typical of appendicitis. So a top missed NCLEX question states which client should the nurse see first? And it's a client with epigastric pain after an ERCP. Yes, just think of the double E's here. Epigastric pain from an ERCP can erupt the pancreas, causing pancreatitis. And bruising is another critical sign. So we have Turner's sign and Coulin sign. Turner's sign is bruising or ecchymosis on the flanks or the sides of the body, and Coulin's sign is edema and bruising around the belly button, also called the umbilicus area. So just think T for Turner's sign, you can see the bruising when you turn the client. And C for Coulin's sign, just think of a belly ring shaped like a C for colon. There's bruising around the belly button area. Now, clients can also present with liver disease symptoms too, as the liver area can get backed up from this inflammation in the bile duct, causing jaundice, that yellowing of the skin, from the elevated bilirubin. And we can also see hypotension, that low BP. This is typically from internal bleeding and even ascites, that fluid in the abdomen that makes the stomach region big and bloated with fluid. So Saunders mentions A client admitted to the hospital, which assessment finding would be consistent of acute pancreatitis? Select all that apply. So gray-blue color at the flank, abdominal guarding and tenderness, and a big one here, left upper quadrant pain that radiates to the back. So again, write these three down and know them. In terms of labs, we have elevated enzymes, specifically amylase and lipase. Now, lipase is the biggest one here. Write that one down. It's always the most indicative of pancreatitis, so it's the most tested. We also see elevated glucose, indicating hyperglycemia. This is from the lack of insulin, as it can't get out of the pancreas too. So just think insulin puts sugar into the cell. So without insulin, well then no sugar can go into the cell. So it ends up just sitting around in the bloodstream, and therefore causing hyperglycemia, that elevated blood serum glucose. So clients may have to go on insulin momentarily. Next, we have elevated WBCs over 10,000, and we can even see a fever from all the inflammation. And since the liver may be having trouble, it can't produce coagulation factors like normal, so we see elevated coagulation time with elevated PT and APTT. Huge risk for bleeding here. And elevated bilirubin, which will cause jaundice, as mentioned before. Now, in terms of complications, typically the most deadly are the most tested. So, number one, write it down, is ARDS, acute respiratory distress syndrome. Many students get this wrong. This typically results from massive inflammation all over the body that can lead to leaky blood vessels, filling up the alveoli inside the lungs with fluid, which we cover more in detail in the respiratory course. The second thing is peritonitis, the inflammation of the peritoneal cavity inside the abdomen, typically caused by bleeding from that inflamed pancreas. So we always assess for and report to the HCP. Write down these top three here. A fever over 100.3, rebound tenderness, as well as a rigid or board-like abdomen. Those three are the most commonly tested out of 10,000 questions, as well as increased pain and tenderness, restlessness, and a fast heart rate and respiratory rate, known as tachycardia and tachypnea. This typically means internal bleeding, and it could mean deadly peritonitis and the patient goes septic and die. So this is a big medical emergency here. So make sure to pause the screen and write those down. Now, in terms of interventions, we always put the patient on NPO. No eating, no drinking, nothing per oral for at least 24 hours. Since eating and drinking stimulates more enzymes, which leads to more pain and more inflammation. Number two is we insert a nasogastric tube for suctioning, so an NG tube. This decreases the gastric, or basically the stomach, to cause gastric decompression. Number three is we use IV pain meds like hydromorphone, brand name Dilaudid. No morphine. A lot of students don't know this. Morphine can cause spasms inside the pancreas that can lead to more pain. Next, we use IV fluids, and we also monitor glucose, specifically for hyperglycemia. Remember, the pancreas is having trouble here, so it can't release insulin. So we end up with hyperglycemia, and the patient may have to go on insulin momentarily. Now for pharmacology, we use the acid reducers here. So antacids, proton pump inhibitors, those end in prazole like pantoprazole, and H2 blockers like famotidine, which we cover in full detail in our pharmacology course. Now a common exam question here is, after performing a physical assessment and obtaining vital signs for a client with acute pancreatitis, which nursing intervention is priority? IV fluids and pain control. And Saunders had a question. A physician orders were written for a client admitted to the hospital with acute pancreatitis. Which order requires follow-up by the nurse? Full liquid diet. Yes, remember, clients should be NPO for at least 24 hours. So we must call the doctor and question the order. Now, eventually, clients will progress to a bland, low-fat, low-sugar diet. In order to give the pancreas enough time to make lipase and insulin to break down the fat, and let sugar into the cell. So write it down. A diet low fat and low in sugars. And we also add enzymes with meals. Now Hesse mentions, which foods would be most appropriate for a patient who recently had a bout of acute pancreatitis? Select all that apply. So remember, before looking at the options, just think low fat and low sugar. So fried chicken, do you think that's okay? No, there's way too much greasy fat. How about potato chips? Nope, too much fat. How about grilled chicken and a baked potato? Yes, the key term there is grilled chicken. How about reduced fat cheese and whole wheat crackers? Yes, the reduced fat is the key term there. And whole milk with cookies. No Santa Claus here. Whole milk has a lot of fat, and sugar inside the cookies are not good. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.